For this morning, a big thank you to the Canadian Foundation for Healthcare Improvement. I think I saw Graham. There he is, Graham Wilkes over there. Is it Director of Communications? Director of Communications as well. Medavie, I don't think anybody from there made it today. And a big thank you to the Hospital for Sick Children and the, I'm going to get it right, the Peter Gillian Center for Research and Learning for supplying this morning our facility. Without any further delay, I would like to introduce the President and CEO of the Change Foundation, Cathy Fooks.
Thank you and good morning. I'm having flashbacks to being a university and not sitting in the front row in case I get picked on by the professor, and I see nobody sitting in the front row, so we promise we won't pick on any of you this morning. So I'm very pleased to introduce JoAnne Poirier, who has been the President and CEO of the Victorian Order of Nurses since 2014. For those of you who don't know, VOwen is actually the founder of home care in Canada. It grew up as a grassroots organization and has a very long history of innovation in health, from frontier nursing to establishing community hospitals. And full disclosure, last fall we were very pleased that she agreed to join the board of the Change Foundation. JoAnne came to VOwen with an interesting professional background, much of which was not in healthcare, so it's a bit relevant to our conversation today. At the time of her appointment to the VOwen, she had been an inaugural member and then vice chair of the Champlain Lynn, but her background was originally in the private and municipal sectors, where she spent a number of years looking after the provision of services to the city of Gloucester near Ottawa. She then left there and went to the private sector to work for a publicly traded American financial institution, but the tug of human services was too much, and she came back relatively quickly and spent 6 years at the helm of Ottawa Community Housing, the city's public housing corporation, serving more than 30,000 tenants and with a real estate portfolio valued at more than $2.5 billion. So an interesting background to come to the VON. So we are here today to talk about home and community care, why it matters, where it could go in an ideal world, and how we might get there. So JoAnne's going to start by setting the stage for us and making some opening remarks, and then we're going to move into more of an interview format. And we have ensured time so that there will be opportunity for you to ask questions and reflect on what you're hearing from us today. So I'll turn it over to JoAnne.
Thank you very much, Cathy, and it's really a pleasure to be here. I see a lot of friends and colleagues in the crowd, so it's very heartwarming. And I want to acknowledge all the work that all of you do each and every day to make a difference in people's lives, because frankly, that's what healthcare is all about. And for me, it was an interesting transition because I do have a private sector and municipal background, but had volunteered in the not-for-profit sector, and that's where the human services interest was developed. And it was interesting because when I sat on the Lynn board, it was as a founding member, we literally had 2 members, a brand new CEO, and a cell phone. We didn't even have office space yet. So that's how embryonic it was. And I was able to see the community through a different lens and developed an intense interest in healthcare. And when I was preparing to leave Ottawa Community Housing, I had interesting conversations with the tenants. And of course, I realized then just how core to a person's being their home is. And working with a lot of the working poor, with people on disability, with people with mental health issues. And when I did some town hall meetings to prepare for my departure, I said to a few of them, you know, I'm going to VON to make sure that you have home care when you need it. And they would chuckle and say, thank you. And I also, on the lighter note, would talk to staff and they would say, geez, you know, you're leaving hoarding and bed bugs behind. And I said, folks, this is home care. I will not be leaving that behind, but rather, you know, spending more time in people's homes looking after their needs. So it's been a very, very inspirational transition for me. When I started, I spent time with a board of very committed volunteers, and I have a couple of board members here, including my board chair, and to see the devotion and the time that they've committed as volunteers to VON has been really inspiring. And spending time with the staff and going on client visits. So what I came to realize in that transition from Ottawa community housing, social housing to health, is that health is the great equalizer. And what I mean by that is, I remember one visit that was of a palliative nature in a downtown mansion where the family was very well-to-do, but the woman was still 65 and dying of cancer. And what struck me was spending time there with the RN and the family who had come up from the States because they knew the end was near, and spending time with them and seeing how much they appreciated the care and the consistency of care that they were receiving. And I left there feeling that not only was it a great learning experience, it was a spiritual experience. It transcended health. And it really made me realize how we are in a privileged position to be in people's home. This is their private space. This is where we build relationships and help them look after their health needs in a way that is outside of an institutional setting, and by God, we need that as well. But by the time people go back home, they're feeling vulnerable, they're not sure what awaits them, and in some cases, you know, going out east and spending time in a veteran's home who's 80 years old, whose only human contact is with the PSW who's coming in to prepare his meal, and how grateful he was for that contact. And it made me realize that it really is not only about health, but about reducing social isolation and wellness. And a lot of what we do in the sector is not only about home care, it's about community and being in the community and spending time at adult day programs and doing things in the community that reduce that social isolation. So those have, you know, part of my journey has been really looking at it from an outsider's perspective, coming in and feeling quite privileged to work alongside very devoted staff. And, you know, I see examples of every day of the staff for whom this is not a job, it's a vocation. And examples would be, you know, hearing when I go out to Halifax that some of the nurses were working with a gentleman who was in his last stages of life. And we could only cover certain shifts, so the nurses got together and agreed to volunteer so that this gentleman would have 24/7 care for the last week of his life. You can't assign a value to that. That's just home and community care. And what I feel a bit sad about is that I feel that it's a bit invisible because we're not linked to bricks and mortar and infrastructure. It's a little amorphous, and I think what you're seeing now is an awakening to the value of that sector and the importance of that sector as part of the health continuum. And another example would be, you know, after I'd been with VOwen for about a year, we have, and you should actually try to read this book. It's called Bringing It Home. And it was written by Tilda Shaloff, who's an ICU nurse who's written several books about nursing. And I spent quite a bit of time with her going to different sites to launch her book. And what she realized was an ICU nurse is very frontline. You do build a relationship with the person and their family because it's such an intense time in a patient's life. She had no idea what happened when the person came home back to the community. And it was an awakening for her. And you really should read the book because we provided to our board members and new staff when they join us. And it really is an awakening and a realization about how special home and community care can be and what it represents for people. And this book is interesting because it's through storytelling. And not only about homes, but rather what happens in clinics where, you know, you have an RN who's dealing with someone who's addicted to drugs, and how non-judgmental and helpful these healthcare professionals have to be in the conduct of their functions. And it really is so impressive and inspiring. So I guess for me, home health is about the human context in the person's surroundings. And you see all shapes and sizes of homes, some that are reminiscent of my days at Ottawa Community Housing, and some others that are in fairly well-to-do surroundings. And it really is the great equalizer, and that makes us all human. And I hope through this discussion, many of you already know this, but to stress the importance of home and community care in the full context of health. And I say health rather than health care because health care is once you're sick. I think the full continuum includes wellness, health promotion, exercise, adult day programs, the full wraparound services around people to keep them well and to prevent disease once, in order to extend their useful life. So that's my opening.
Okay, thank you.
Thank you.
So before we get into home and community care of the future, let's just spend a minute on VOwen and where it is now. The last time VOwen was in the news to any great degree, it was an organization under some threat. So can you kind of walk us through what you faced when you arrived in 2014 and where you are now?
Sure. So when I was hired by the board, they were extremely forthcoming and transparent about some of the financial challenges. And here we have an organization that was founded in 1897 and has been innovative and really trailblazing, founding community hospitals, turning it back to the community once started, working through the Depression and both wars. We get to lay a wreath on the hill on November 11th because of our contribution to Canadian society. And what we came to realize is that we also, as a not-for-profit, have to operate as a business and bring business rigor to the forefront. And so I went in with my eyes open. I had not anticipated, though, that a year later, that because of some changes in our funding with the Nova Scotia government, and because of some investments we had made in technology that had incurred a debt, that we would be facing a situation where, to save the organization, we would have to do financial restructuring. And what that means is looking at what business you should remain in and where you're bleeding financially and where it simply does not make sense to continue. And so what we did was to look at where we could pare back. We did have to exit a few provinces where the models had changed, and I know Cathy will be speaking to me about that in a few minutes. We had to make some very tough decisions, and I can say that 2015 and 2016 are almost a blur in retrospect. To put it in perspective, of our almost $300 million budget, it represented in aggregate only $10 million. But it still impacted 350 staff and the clients that we had to seek alternate arrangements. So a very, very soul-challenging exercise. And I have my board to thank for having the courage to support the recommendation when we sadly had to make it, that we had to go through that process. We benefited from tremendous support from senior staff. We had to make some difficult decisions. We're talking about locking doors with no, forewarning, with security guards there, and really having to lay off staff. And it was very, very difficult and very stressful. But we also knew that VOwen was worth saving, and that we had to make those tough decisions in order to save an iconic organization that helps 10,000 clients per day. So where we are now is that 2015 and 16, we went through financial restructuring. We did emerge from CCAA protection, and 2017 was a great year of stabilizing our foundation. So what we have done is to effect a lot of cultural changes. We have a huge heart at VOwen, and I've spoken to the devotion of the staff, but bringing the head part into assigning business rigor and lean management practices and productivity enhancements. And it's interesting because through this process, you can imagine that our staff were feeling insecure. We still have 6,500 staff who are hoping to have a job, and 6,000 volunteers who hope to continue making a difference. And our funders were looking to us to say, are you going to make it? And I can't say enough about the support that we got from our funders in both Ontario and Nova Scotia. And I remember being on the phone the day it was going to go public with the Minister of Health in Nova Scotia and saying, Minister Glavine, we're here to break some news to you. And you know what his response was? Good for you. good for you for grabbing a hold of it and restructuring your business so you can be here for another 120 years. I mean, what do you say to that? I still have chills when I remember that moment. So we got tremendous support. We met with Bob Bell, same reaction, good for you, and keep us posted. And through that support, we were able to look at re-engineering our business. And I can tell you that it has made us stronger as an organization. We are never going to forget what we went through. We call it going to war together. And it really does kind of feel like that. But I'll tell you, the end result is one that's very gratifying. And we are on a very solid financial footing. And we have learned a lot of lessons. And a lot of lessons that are embedding a different culture. And, during this time, I was going out to the different sites to have town hall visits. And I remember I said to the nurses, we have a huge heart. We have to bring the head into it. And a nurse asked me, it was the perfect question, if you use your head more, won't you lose the heart? And I said, no, it's the reverse. If you use your head and you strengthen your organization, you're going to help more people ultimately. So you do strengthen your heart. And it was like an aha moment for them to say, it's not heresy to say we have to be businesslike in our approach. We do have to pay attention to managing our performance and to looking at key performance indicators. But remember the end result, it's about helping people. And it's served us well. We're not there yet. As you know, culture change is a journey. You're never quite there. And if you think you've arrived, you're complacent or arrogant or both, because it is an ongoing continuous improvement journey. And it's something that we're very mindful of. We're very excited about the future. And the reason that we emerged quietly is that we did hurt some staff in that process. And we didn't feel that it was appropriate to celebrate, aren't we great, we're still here, but to quietly go about our business and to make sure that we treated staff as fairly as we possibly could in very difficult circumstances, as well as the clients. So when we did exit those provinces, we made whatever arrangements were possible with other organizations through our funders to see if we could minimize the impact on our clients. So I can say it was very difficult. I'm exceedingly proud of what we've accomplished together. And I have the board to thank and our staff for helping us get to where we are today. And we do look forward to being here for another 120 years.
So let me just pick up on something you said about why you were leaving. Yes, there were financial reasons for it, but you said that there were system changes that, that were presumably beyond anything that home and community care was doing. Can you just talk a little bit about the changes in the models? Because obviously here in Ontario, we're in the middle of moving towards a different future as well.
So an example would be in Alberta, where they centralized a lot of the healthcare delivery. And so in those instances, what we were left with were very small business units, flu clinics, foot care, that sort of thing. And you all know, those of you who run a business, that you have to have enough of a base and enough time and enough money to invest in that business in order to grow it. And we didn't have the luxury of time, and we didn't have deep pockets. So where you look at restructuring, I think that what we have to make sure is that sustainability is the key, and that whatever changes take place, that you can have the resilience. And it's funny because I often get asked, will you be reopening? Because a lot of our volunteers really bemoan the fact that we're no longer in those provinces. And they'll say, do you see going back there someday? And I always say, if it makes sense. And that's what we have to do, is we've developed a template for business cases, and before we enter a line of healthcare, we have to make sure that it is sustainable. And so there are a lot of changes that were outside of our control, and while we tried to make a go of it, it simply was not sustainable. And it's interesting because at one point we were asked to comment and to provide advice on a national dementia strategy. And we appeared in front of a Senate committee, and one of the senators said, Ms. Poirier, I have to ask this question. With the need for home and community care, why would you have exited those provinces? And the response was, because it didn't make sense financially. And we as a not-for-profit have to operate in a business-like way. And because we're not-for-profit doesn't mean we have to operate at a loss. We have to at least recover our costs. So that's something that we have to continue being mindful of.
Right. Okay, thanks. Okay, so let's look forward. Ideal world, what does home and community care look like?
I have a few key words that I want to refer to. And, you know, we all know that there's no silver bullet, because if there were, we would already be there. And I think what we are looking for are the key words that I'm going to speak to in terms of access, and making sure that people who need the services have access to the right services at the right time in the right way. Clarity is about information and how people can go to get the answer and get the service. And of course, the seamlessness, which is that dirty word called navigation. We all know how challenging it is to navigate the system. So, you know, whether we as a continuum with government look at re-engineering and mapping the process so that it does make sense, and so that the primary care teams connect with hospital and clinics and home care providers, those are things that need to be looked at. And I remember Bob Bell at one point saying, if you can fix a navigation problem, you have me at hello. And that is the challenge. And it's a really challenging situation, but it means we have to work together and to have respect for each other and what we offer to the sector. Choice. Our sector really supports the notion of choice and self-directed care. And I think that, you know, it's not a matter of saying, well, you qualify for X, when the question may be, what is it that you think you need? And each situation, we all know, is different, because you may have a family caregiver that's prepared to do certain things, and you need professional, licensed healthcare professionals for other services. Sufficiency, there has to be sufficient support. Affordability. And that's the challenge that our governments face, that we all face, is how to spend the healthcare dollar differently to have a greater impact. Capacity building, and what that means is looking at the volunteer base and the family caregivers and supplementing with professional healthcare. We all know that if we did not have family caregivers and volunteers, the system would be brought to its knees. So how do we leverage that and provide more support? And I know the government is starting to look at those things. And sustainability. So those are key words. Those are the things we're trying to achieve. How do we get there? I think we need to continue having those discussions and looking at doing things differently. Einstein said it many years ago, right? So I think that what we have to do is get around the table and map out the process and look at where the glitches are and how we can make things different and better. And I think that means, and I'll say something that might be viewed as a little bit provocative, but I feel in a way, because I'm a newbie, I can say it still, is I'm struck in some pockets by the respect for the sector, and in other pockets, there's an inference that we're a body shop. We're not a body shop. We have the same professional standards as any institution, any healthcare institution. And in fact, I would challenge people to realize that these professionals are in people's home each and every day. They have more autonomy. They don't necessarily have a team around them at all times. We access virtually and through the phone and through team huddles. But in fact, it's a special place that folks occupy, and I think they need to be assigned the respect that they earn each and every day. And that speaks to one point that I have to make, which is in Nova Scotia, where we provide 95% of the nursing, there is wage parity between home care and long-term care and acute care. In Ontario, our nurses make $10 less an hour than in an institutional setting. That's a real challenge, and I think as the system realizes that home and community care, we're talking $50 or $60 a day as opposed to $1,000 in an institutional setting, you have to realize that things have to be funded differently. And if we want to attract and retain PSWs and nurses, we have to look at compensation differently.
So I have to ask this question because you raised it in terms of choice and self-directed care. As the room may know, there is now currently a lawsuit against the new Personal Support Services Ontario agency. Do you want to comment a little bit on that?
Well, what I can say is that we, as a sector, have come together, and we've been doing that for many years around the policy tables, working very closely with government and being consulted. This is a different situation that greatly concerns us, and we completely support self-directed care, and everyone agrees that the rule book right now is very rigid and not conducive to flexibility and not reflective of people's changing needs. But we do not believe that creating another bureaucracy is the way to do it. And what we would hope is that the government would cease and desist and sit down with the sector and leverage our decades of experience that we have, professional experience providing services, and figure it out together. So that's our hope through this process.
Okay. So you've described kind of what you'd like to see in the future. Now tell us kind of how you see getting everybody moving in that direction.
So I think we have to start having different conversations and really sitting down as a sector with government to look at what is the art of the possible. And it's not through pilots, it's through system change and system integration, but with us as an equal partner at the table, leveraging our expertise. And what that looks like in a detailed fashion, I think we need to figure out. I think there are many good initiatives afoot, and I need to acknowledge that. And, for example, LIN subregions where you can't boil the ocean, but rather each community has different needs, and working alongside sector partners and really bringing the different partners to the table to have a look at those solutions. So there's some ground up and top-down solutions that need to be looked at. And, as we have that lived experience that we can share, that then should drive policy changes and really working more closely together to figure that out.
So a lot of what you've described is obviously well beyond what one organization can do. So how do you envision a way in which agencies who are actually in competition for service dollars can work together both within home and community care and beyond?
Yeah, and we've already been doing that. We have worked very collaboratively with some of the LINs, for example, to make geographical changes so that it makes more sense. We're at various policy tables. We are part of associations like Home Care Ontario and OCSA. So the sector is used to working together, and we have to respect that it is a competitive landscape, but people have a shared vision that's bigger than one institution, and we have to work together. And I will tell you that the creation of that coalition, for me, has been an eye-opener, and I'm very impressed with my partners and how we have been able to work together towards a common goal. So I think that that's not an excuse to do nothing. Mm-hmm. And I think we have demonstrated that we can work together and sharing that experience. And it's, we are not for profit, we're a charitable institution, but the for-profit organizations still warrant respect because they're there to provide good care too. So we need to work together.
Okay. So we're going to turn it over to the room. As you can see, JoAnne's given you lots of things to think about and is also, I think you can see, a very open person. So I think she'll take any questions or comments that you'd like to make. So I'm not sure how this works now. I think I'm looking for red lights, right?
I've got a red light.
Okay.
My name's Hugh Armstrong. You've spoken a lot about lean management and re-engineering and so on. As you're learning to do things differently, are there ways in which the logic of business conflicts with the logic of care? And if that is the case, how do you address the conflicts?
So I don't think they're in conflict. I think it means a different kind of approach. So, for example, the system can no longer afford a nurse having a cup of tea with Mrs. Jones necessarily, but changing the language to say, I'm here addressing your wound. Is there something I can do before I leave? So while you have a certain length of time and certain number of clients that you have to visit in a certain day, still taking that personal human approach. And it's just working differently. And it's being cognizant of the fact that, you know, if you do see more people during the day, you have to really make it count when you are in their home. And the fact that you are seeing more people in a day, you're ultimately going to be helping more people. And, you know, it's also, we are the eyes and ears in the community, and strengthening the partnership with the government is helpful because, as an example is in Nova Scotia, we work closely with the care coordinators. And if we're in the home and we recognize that the needs have changed, we can then feed that back to the government. If the changes warrant less care, that also is a conversation that we can have with government so that they can make the changes and somebody else can benefit from that time. So it really is working very closely, and they do not conflict. It means working differently. But I think, you know, to the point that I made when I spoke to that nurse at that town hall meeting, being more cognizant of productivity means you can help more people, and people actually have come to realize that that makes them feel better. So as we rolled out mobile technology, and our nurses at first were mortified and saying, wow, I don't know how to deal with this, they now embrace it and say, you know, it's a useful tool and it really helps them operate in a more efficient manner.
Okay. There was a flashy one at the back. Hugh, turn your mic off. Okay.
Okay, actually, it went up to the very top there.
Hi, JoAnne. It's Janet Daglish from Bayshore Healthcare. I just wanted to thank you very much for your trailblazing approach as a nonprofit, and I would like to totally reinforce your comments that, you know, as a sector, we have become much more collaborative, working together at many of the tables, and I think we all very much hold that vision of how can we make the system better. So I wanted to just reinforce a couple of points you made and then leave you with a question. The point around the autonomy of our professional staff in community is such a good one. Our nurses have to have the autonomy to be able to support a patient going through an oncology treatment journey. They have to be able to be experts in wound care. They have to be able to address any clinical needs. So they do have higher autonomy requirements. Most of them have a lot more of these certifications and training and education, which is a significant investment. And yes, thank you for reflecting. It's been 10 years since nursing bill rates have seen any changes. It's really hard in the home care sector to continue to support that investment. So my question is, we've had a lot of focus recently on PSWs, but we need to advocate for our healthcare professionals. But if we have a vision for creating more integrated teams, which you referenced, how do you see us working together to create more of an integrated model that really helps support the patient and their family along their health journey?
So I think it's recognizing that it's a multidisciplinary team that is needed, and spending more time with the client and the family, assessing needs, and then making sure that whether it's an RN, an RPN, PSW, occupational therapist, physiotherapist, speech pathologist, whatever the need is, then actually making sure that that team is trained to surround that patient and to work very closely together. And, you know, I want to address the theme of autonomy. That doesn't mean that the person, if they have a question, can't access, because we've made the point publicly that PSWs benefit from RNs and maybe, you know, many healthcare professionals around them to provide that guidance and that support. So we already take a multidisciplinary team approach, and I think as people are being discharged earlier and earlier from the hospital, because they do want to be home, and because it is more affordable for the system, I think that warrants an even more multidisciplinary team to surround that person. So, and I think we're on our way, but more needs to happen in that regard. Thanks, Janet.
Yeah.
Hi, it's Ron Noble. I have a question. In terms, many nonprofits have, in the late 80s, 2000s, went through the re-engineering, the lean processes. So my question is, has VON really caught up to where the nonprofit industry was at? Or can you give examples of where there's been innovation, whether that's in labor mix, whether that's in lines of business? Because many organizations stepped back and realigned their strategy and got into the lines of business they should be in and got out of the ones that were on the margin, or gave up on the ones that should be delivered by other providers. So I'd be interested to just understand what kind of innovations that you could speak to and what areas they were in.
So we've innovated throughout the decades, but the most recent examples would be, the e-shift and e-rehab, and using technology to have a directing nurse be able to oversee the work of several skilled technicians in people's home, whether it's palliative care or, pediatric complex care patients. And I think the use of that technology is enabling us to help more people at the same time. The other thing that, a lot of things that we have successfully done in Ontario, we're currently discussing with the Nova Scotia government. And so some of those innovations require technology, and some are more about human power. And what I mean by that is, let's not discount the importance of, rather than a PSW going into a home to prepare 3 meals a day, the Meals on Wheels program with the use of volunteers is a great way to provide that and still reduce social isolation. So there are many examples using technology. Our eShift program, lean management. We have done a lot of lean management re-engineering at the front line. We're now looking at our back office and how we can make certain changes in that regard. And I think that I wouldn't say that we had to catch up. I think what we had to do was to resort our business so that it was more sustainable. And the thing is we celebrate our long and distinguished history, and sometimes that can sound stodgy. We actually, sometimes I think, my personal opinion, undersell ourselves because we've actually done a lot of innovative things, but we choose to be quiet and humble about it. So the innovation portfolio is something that we are growing. We're doing it in very quiet ways. Another example where we've worked with one of the LHINs is the SMILE program, which is Seniors Managing Independent Living Easily. And what it is, again, a form of self-directed care where an investment of funding is attributed to us to coordinate on behalf of the patient, the client, as their needs change, whether it's clearing the snow or delivering groceries. The thing that keeps people at home often is not necessarily of a clinical nature, but rather a basket of services. The other thing, too, is the term community needs to be stressed because it's not just about people in their homes, it's about getting them out into the community. An example of that is the Adult Day program. I was in Barrie a couple of years ago speaking to a gentleman who was 82 years old, as fit as a fiddle, downhill skiing a couple of times a week. His wife has dementia. He gets to drop her off at the Adult Day program. He gets to stay fit and healthy and gets respite and a break so that he can pick up his wife at the end of the day. She's had social interaction, she's been stimulated, she's happy, and he's healthier as a result. So the innovations that we're talking about aren't flashy, but they make a significant difference, and we are continuing on that journey.
Thank you.
I think Ray's is next.
I enjoyed your presentation, but what I was wondering is, given the heterogeneity of what's meant by home care, at one end, the acute care substitution, where you're doing care that would otherwise be in a hospital. The other, the prevention maintenance. What do you think should be paid for publicly? What's the similarities to childcare? And to what extent are we assuming that everybody will agree that everybody should have their snow removed, as opposed to everybody would agree that palliative care needs to be given? And how much of an issue is the fact that this is a very heterogeneous thing where all of us could use somebody shoveling the snow, whereas most of us don't need somebody caring for terminal cancer?
That's a very big question. It's a very... We're not going to solve all the problems of the world this morning, but I think what you raise is a very valid point, is one that we have to look at the different parcels and what elements are about promoting wellness and preventing disease, what elements are about keeping people in their home in an economic fashion. And, this may sound provocative as well, but we're already in a two-tier system. And I think the recognition is that, longer term, that's going to continue. And I think we have to stop fighting that notion and perhaps embrace it strategically and have a look at, how the pieces fit together differently.
I can't tell. I can't see the lights.
Oh, there's another one.
Yeah, start waving your hand.
Yeah.
There we
Hi,
go.
Good morning. My name is JoAnne Vautour, and I'm leading the engagement with First Nations Inuit Métis communities with the Ontario Palliative Care Network. And so in my role, I hear a lot about the issues and challenges with access to home community care. And I wanted to know with VOwen Canada if you've had any experience in collaboration and partnerships with any First Nations Inuit or Métis communities.
Yes, we have at VOwen, and we have some pockets of work in the Thunder Bay area, I believe in Northern Ontario, and we certainly have an interest in further pursuing collaborative partnerships with Indigenous people. We recognize the uniqueness of some of the needs and the importance of working collaboratively and really understanding not only the needs, but how people wish to work with us. So it's an area of interest. I would love to have a further conversation with you.
Great, and thank you. And I just wanted to, acknowledge and say thank you for talking about in the work that we do and how we also use our heart and with our mind, and that's a worldview that First Nations people talk about. It's not just using our mind, but it's our heart too. Thank you.
Thank you.
I think I saw Gail's light going. There we go. Just yell.
I guess it's me. Hi, Pam Hubley from Sick Kids. Welcome to Sick Kids in our beautiful space, and thank you very much for your thoughts. I had a similar question to the previous one. I just a little bit more broadly. I was wondering about cultural competence and how that is addressed within the community. Providers and specifically the role that VOwen would play in ensuring individuals have access to providers and supports that really are compatible, sensitized, and really supportive of their needs and perhaps different languages.
Mm-hmm. Yeah, and I think
complexity, I would think, in the community.
It is, and I think it's any organization has to step back and look at the changing needs demographically, and what cultural sensitivities need to be brought to bear. And we have a robust quality quality practice group that looks at what are the changing needs and what professional development we have to bring to bear. And also, it's not just the professional development, it's also hearing from our providers in terms of what they are seeing in the community. And the uniqueness of VOwen is that we have a lot of community support services, so we are out in the community at all times, gauging what the changing needs are and working and collaborating with many not-for-profit organizations. So that brings back a lot of information that we then leverage to make sure that we try to stay on top of that. It's an ever-changing landscape, as you know, and I think that we can always do a better job of it, and it's certainly something that is one of our priorities, because we do recognize that the population is changing, not just the aging side, but also cultural diversity, and the need to better understand that and to be sensitive to it. Because when people are sick or unwell, they are stressed, they're feeling vulnerable, and I think it's really important that we provide them with that comfort, that people understand, and that we are sensitive to their needs. Yeah.
I'm red. Okay. Hi, Amy Olmstead from the Ministry of Health and Long-Term Care. You mentioned one of the strengths you see of the Nova Scotia system, which was pay parity for nurses amongst within or between rather the different sectors. What is something else that works really well in Nova Scotia that you would love to see here in Ontario?
Well, that's a big question. One of the things that has served well, and I think they are two different provinces. You're talking about a province of 1 million people versus 14 million in Ontario. One of the changes that the Nova Scotia government made was to consolidate the health councils and the health authorities into one. And so that has simplified things. And, you know, they work very closely with the Department of Health and Wellness. And I think what they're looking at is a distinction between the policy framework and also service delivery. So we are working very closely with them as partners. And I think the importance is the word partnership. So I think Ontario is more complex. We, though, have been talking to the Nova Scotia government about a lot of things that have worked well in Ontario, such as the provision of community support services, not just in home care, but outside of the community. So I think because of the smaller scale, we're going to be working on a few pilots to test out things that have actually worked well in Ontario. And so I think they're two very different provinces, and what we're hoping to do and the value we're hoping to add as a partner is to share with both entities what's worked well in each other's provinces. Yeah.
Hi, my name is Joyce Chan, Minister of Health and Long-Term Care. Thank you for your talk. My question for you is, you mentioned that lived experience as being a key part of policy change. So my question for you is, what are the indicators that you're currently using to measure, patient, family, caregiver experience within home care, and what are the indicators you'd like to ideally measure? And my second question for you is, what are some strategies that are being used to really engage with people in the community and to ensure diverse representation?
Okay, so that is very much a journey that we're on, and I'll say that as someone who came from outside the sector, and I say it sometimes to staff, is, the healthcare system is late coming to the party in terms of recognizing that the customer has to be part of it, and better late than never, but I think it's been more of a traditional, I'm the healthcare professional, I'm going to tell you what you need, and realizing that that's really not the answer. So we're very much on a journey at VOwen. So we have created councils, and we are engaged with those volunteers. The other thing is, because we're in people's homes, I think we engage with patients and their families each and every day. And so it's bringing back those practices. We have adopted a policy that states that increasingly, as we look to secure certain positions and professionals, we're going to be engaging patients in that selection. We're looking at the composition of our board, and very much a lot of the same standards that Accreditation Canada is looking to change. So we are on that journey. And I think the sensitivity is with healthcare providers is that we have to get them to see that it's not a criticism of what they're currently doing. They're doing a lot of things right, but it does mean working differently. And someone once said, if you're not feeling uncomfortable about some of those changes, you're not doing enough. So I think that it is very much a journey. We have adopted a policy. We are conducting a lot of training for our staff, including, modules that I followed myself, that really speak to what it means to be more sensitive and to work more closely with the client and family, and how to engage them. And it's really not about information provision, it's about treating them as a full partner. So in the same way as the home and community care sector is saying, treat us as a full partner, we have to treat our clients and their families as full partners. And that means making a lot of changes to how we operate and how we work with them.
One more.
Hi, JoAnne and Cathy. Thanks very much. My question actually, or my comment, is more related also to the client and family and what happens there and how we'll know when we've been successful. So first I'm going to tell you my anxiety. My anxiety around our current efforts in patient engagement is we are at risk of what I'll call institutionalizing the patient voice. And so everybody's got a million committees, and they're all searching for caregivers or clients to put on these committees. And I'm privileged to go around and see lots of these committees, and I'm meeting a lot of the same faces. And I don't know how, as we search to partner with clients and families, which, by the way, I think is way more important in the home. Frankly, I give a lot of credit to hospitals who are doing it, but doesn't matter nearly as much as in the home. A lot of people in the home are going to be receiving care for 30 years. Hopefully, nobody in acute care hospital is going to be there for 30 years.
Yeah.
So it's a very different kind of culture and a very different kind of need for family involvement and engagement and partnership. So I'm concerned that the relationship, and we're not moving quickly enough to a real partnership with clients, and that we'll soon be very satisfied when we've got people on boards, when we've got people on committees, when we've got advisories and whatever, and I'm glad we're doing that, but that's not really the answer. The answer to partnership is on the ground.
Yeah.
So you've talked a lot, you've made a tremendous amount of change at VON, and I give you a ton of credit for how you've emerged, and wish you lots of good luck. But this is critical if we really are going to change the culture of care at the client level. Yeah. And the client level, of course, is as many homes as there are. That's how much difference there is. There's no grouping together.
So Gail, I couldn't agree with you more. It's more important than any other place, because home is where the family is and where the client is, and those longer term relationships. So, it is, to the earlier question too, is about looking at health outcomes. And, we had a client story where we interviewed a gentleman and his daughter, and we asked a lot of questions of them in terms of what worked well for them and what didn't. And what I was struck by was the fact that a lot of it was relationship-based, is making sure, and we all strive for the continuity of care because people do develop relationships with the caregivers. It's not always possible to have the 24/7 obviously be the same person. The thing that struck me about the interview that I saw was the daughter said that the caregiver, our frontline person, asked if they could show her how to do a certain procedure for her father, and she was not comfortable doing that. And she felt respected by the frontline person, that they allowed her to not feel comfortable doing that, but that eventually maybe she could feel comfortable with that procedure. And it's those kinds of conversations that we have on a daily basis. So we are a living laboratory for those stories, and what we have to do, and you're right, you can't apply the same methodology to everybody because each story is different. But we're going to institute the learnings through those client stories and bring back those learnings. And that means empowering our frontline staff to come back with those stories and to really share them with all of the staff that need to learn from them. So it's not just through the provision of committees and councils. You're absolutely right. It's by listening to those stories. And, you know, we have committed to our Quality, Risk, and Client Safety Committee and to our board to bring back some of those stories where things have worked well and things did not work well and what we learned from them, and really engaging clients and families and telling us how they would want to see things change. So it's not just ticking off the boxes, but rather really changing how we do things. And it is most important in the home, you're right.
You know, according to my phone, we have 2 minutes left, so we have time for one more.
All right. Hi, my name's Cathy Kastner, and I am one of those patient voices involved in research and advisory boards. I'm also a palliative care evangelist. And in my journeys with the various healthcare staff, PSWs, nurses, whatever, there still seems to be a lot of misconception about palliative care, fears and pushback amongst the staff as well as amongst us patients' caregivers. Is there support that you provide or training for your staff so that they are not fearful of that P word?
Yeah, that's a really good question and an important one. And, you know, when I first heard the definition of palliative, I think people always assume that it is leading to the person dying, and that's not the case. And it's about symptom management and those kinds of things. And yes, we do provide palliative care training. There's always more to be done. We provide a lot of palliative care support in the home. We do also have one residential hospice in the Oxford County area and another one that we're looking to build in the Durham region. And a lot of those learnings will be brought to the forefront as well. I think that, you know, I've heard the other day that there were cafes being started for society as a whole to start really, you know, feeling more comfortable with the notion of palliative care, but also dying with dignity and the whole issue of medically assisted dying. And I think it's not only do we want people to live well, we want them to die well and to die with dignity and in a way that they choose. So it's a sensitive topic. It's becoming less sensitive, I believe, as people become more aware that that is really part of the life cycle, isn't it?
So very, very quickly to, as we close here, Rebecca, who, I don't know if everybody's met Rebecca before. Rebecca Hart, my sister, she's been with Longwoods longer than I have, and she let me know that this is possibly the best conversation we've ever had at Breakfast with the Chiefs, so congratulations.
Oh, there you go. Well done.
Our next Breakfast with the Chiefs is May 15th with Peter Vaughan, the former Deputy Minister of Health for Nova Scotia and the current board chair for InfoWay. Other than that, have a great morning.
Thank you, Madame.